You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes. You can also follow us on Twitter at ASAMorg and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Shawn McNeil. Today, we're welcomed by Dr. Jed Barash, who is a neurologist from Massachusetts. He'll be joining us to discuss his upcoming article from the Journal of Addiction Medicine titled Application of an Existing Syndromic Surveillance System to Quantify Possible Cases of Opioid-Associated Amnestic Syndrome in Massachusetts. Welcome, Dr. Barash. I'd like to start by having you tell us a bit about yourself and why you study addiction.
So, my name's Jed Barash. I'm a neurologist from Massachusetts, and I think my path to addiction-related research is a little circuitous. I was working as a neurologist in a cognitive disorders clinic outside Boston in 2012. As part of my first month or so on wards as an attending, we had come across this case of a younger guy who had come in for some tingling in one of his extremities after an overdose, thought to be a heroin overdose, and his parent was with him, and she actually mentioned that he was amnestic. He had really severe memory loss, more so than just being, coming out of an intoxicated state. And when the neurology team examined him, he had a really dense amnesia, inability to form new memories, and we wound up doing an MRI on him. And he had this unusual pattern of damage just in the hippocampus, the memory center of the brain on both sides, and only the hippocampus. It was like if it was almost outlining the hippocampus in an anatomy book. So it's a really striking image, and none of us had seen it before. It's something that we were curious about. His memory loss had, persisted for quite a long time, and, didn't return back to baseline really during the time we were, following him. And what wound up happening was that I was in clinic a couple of years later after that. We had never written up the original case because it's like one thing goes to the next, and it was just you get busy with something, and we thought maybe it was like a fluky thing. And I wound up seeing another guy who had a history of opioid use, supposedly in remission. And the family had left on vacation. He stayed behind. And when they came back a few days later, he had this confused state, wasn't sure, why the kids weren't in school, that type of thing. They wound up taking him to the emergency room. He had a workup. Actually, it didn't include a toxicology screen, surprisingly enough, but did include an MRI. The MRI was read as negative, and he was still having trouble remembering, new things when he saw me about like 6 weeks later. And so when I wound up taking the disc of the MRI from the ER that they had, I wound up, looking at the end of the day because, it gets busy during the clinic day and you can't really get the time to sit down and go through all the images. And what I was struck by was it was like the exact same images as the person I had seen back in 2012. And I was like, wow, this is pretty crazy to see this pattern again. And this person also had a history of connection between the opioid use and the amnesia and the imaging findings. And then we wound up kind of going from there.
Okay, great. Now, can you describe opioid-associated amnestic syndrome and its clinical significance?
Yep. So basically, what wound up happening was we wound up identifying several other cases in our system historically through record review. And then subsequent to that, contacted the Massachusetts Department of Public Health to put out a bulletin basically for clinicians to see if they had reported anything similar. And so, by 2016, we had this notification go out, and it was responded to pretty quickly. We wound up identifying an additional 10 cases through record review. So we basically asked people to submit identifiers that we could review the records with, and we compared that to a case definition that we set up, which was essentially acute onset amnesia, and this particular MRI finding, which was essentially stroke-like damage in the hippocampi, which we said may or may not be associated with opioid use, because we wanted to cast a broad net. So we got these 14 cases where there was a really strong history of opioid use. 13 of the 14 either tested positive for opioid use or had a hit. So we thought there was something unusual going on based on that pattern alone. And we wound up, because of the, these cases had emerged around the time that in Massachusetts, these cases had started to emerge around the time that fentanyl had emerged as a major issue in the drug supply and the illicit drug supply. We asked clinicians over the course of this following year, we made a reportable disease and asked clinicians to test for fentanyl, its analogs, and metabolites if they were to see a case. And over the course of that year, we wound up identifying 4 additional cases in Massachusetts, all 4 of which tested positive for fentanyl, and 2 of which tested positive only for fentanyl. So those cases wound up being those 4 cases wound up being reported in New England Journal, and then we wound up kind of going from there. So the amnestic syndrome, kind of as we know it now, is really this acute onset amnestic syndrome with bilateral hippocampal damage, and really characterized by dense anterograde memory loss, so difficulty forming new memories. And it really seems to last for it's not transient. It seems to last for at least months. Follow-up's been limited, but in some more severe cases, it can go on for a year or even longer.
Okay. Now, can you comment on the surveillance and reporting mechanisms that were utilized to gather data about these cases?
The initial the initial surveillance mechanism that we used was kind of traditional reporting. So we put out a bulletin and we asked for clinicians, it was really targeted to clinicians who would be most likely to see these types of cases, like neurologists and radiologists, like emergency medicine. But it was, the idea was to have them report if they had seen a case that sounded consistent with our case definition, which as I mentioned was really focused on the sudden onset amnesia and these hippocampal findings. And so they basically what would happen was they would contact us either by phone or by email to say I've seen a case. We would collect the information, and then we had the authority as the Department of Public Health to collect that information and to review it for public health purposes. And so we wound up in those cases, we were able to really go through the medical record and actually confirm that those cases were consistent with the definition and what we were seeing.
Now, to clarify for our listeners, were there clinical features that would indicate opioid-associated amnesia versus amnesia from another etiology?
Well, I think so the amnesia is, I would say, is predominantly with the formation of new memories, and it's like, for example, probably like clinically, what it probably looks most like in terms of just the amnesia might be like something like transient global amnesia, where somebody's it really like has no ability to form new memories. A transient global amnesia, by definition, lasts less than 24 hours, and usually lasts far less than that. The demographic of the people with the opioid-associated amnestic syndrome seems to obviously match with pattern of opioid use. It tends to be sudden onset memory loss, often a younger person, and generally the ages have been probably between teens and 40s, although we've had some cases older than 40s, but not very commonly. So you're looking at kind of the population who's affected by it. Transient global amnesia may be probably a little bit more spread out, demographically. So that's probably the big one that looks similar clinically.
Okay. Now I want to get to the commentary about your piece by Richard Dutton, which raises a handful of important considerations. Firstly, he questions whether OAS is coincidental or the cause and effect result of opioid ingestion. So, is there some indication in the data that would establish a cause and effect relationship?
Something you would want to think about for anything, that's, any type of new emerging condition that comes up, is you want to see is cause and effect. One of the ways you kind of look at that is like, is there a plausible mechanism by which that could happen? And there actually has been a fair amount of preclinical work looking at opioids and hippocampal injury. And actually a lot of that was done between the 80s and the early 2000s. Andy Kofke, who's an anesthesiologist at the University of Pennsylvania, who I've partnered with in some work and continue to partner with, did a lot of that, like, real groundbreaking research in work with rodents and even primates. And what they found actually is that high potency opioids like fentanyl and some of the analogs, what it actually does is it causes it almost supercharges the metabolism of the hippocampus and some of those associated adjacent areas, those limbic structures. And so when they administered fentanyl and similar medications in these animals, they were able to identify excessive metabolic uptake, almost like excessive electrical activity, almost like seizure-like activity coming from the hippocampus. And then they were able to, sacrifice the animals and look at it pathologically and identify injury in those, in those areas. So there is some, reasonably good, mechanism there to support that.
All right. Now, Dr. Dutton also suggests that opioids are often not pure and may be mixed with other substances that might contribute to hippocampal changes. He gives cocaine as an example. So I was hoping that you may comment on whether you think that there may be a combination effect, or if you think it's mostly due to the opioid.
I think there probably is some combination effect. So if you look back at case reports, probably dating back like 15 years ago, really before the fentanyl wave of the opioid epidemic, there's like a handful, maybe like 2, maybe 3 case reports of supposedly, this type of picture being seen with cocaine. So it's possible it's seen with cocaine. I would point out that those cases didn't specifically test for fentanyl or analog, so I can't say specifically whether or not that was the case. I mean, it wasn't as highly available back then as it is now in the supply. But I think when we look kind of like epidemiologically, what we're finding is that the cases have opioids on board, or a history of opioid use almost universally, as where a history of cocaine use or identifying cocaine in the toxicology is like represents a subset of the cases. And I think my sense is probably that cocaine and those types of stimulants may essentially like augment, may augment the effect in some way, maybe through, some people postulated that it might be through vasospasm or some other means that it might actually, stimulate a similar kind of, a similar change that you see with the opioids as well. But I do think I think what we're seeing now is primarily opioid driven, and potentially some of the other substances like in the supply may be like amplifying that. It doesn't seem to be like one of the things that he raises a question about is like would be like contaminant or adulterants, and I think a common contaminant or adulterant would be less likely, and part of the reason for that is that those tend to be really epidemiologically limited in geographic and temporal scope. This has been going on for for 10 years now across multiple countries, and such a wider distribution, it doesn't seem plausible. And there's even a case, there was a Canadian case study of a woman with a painful episode of multiple sclerosis who had used opioids in the past, and apparently had run out of the opioids she was using, but had maybe fentanyl from prior, and applied 2 patches to herself, and developed the syndrome from pharmacological fentanyl, which again would support kind of fentanyl as like a primary driver without necessarily invoking a contaminant or other other illicit drugs in the mechanism.
All right. Well, I want to thank you so much, Dr. Barash, for coming on the program. Again, his article will be featured in an upcoming issue of the Journal of Addiction Medicine and is titled Application of an Existing Syndromic Surveillance System to Quantify Possible Cases of Opioid-Associated Amnestic Syndrome in Massachusetts.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.